Hello, everybody, and welcome to episode 45 of CCA's Medical Minute, sponsored by Kroger Health. I am here today with my colleagues, Andy Guinea Gundo.
Yay.
Got it first.
Crushed it.
Take one.
Yeah, that's
Oh,
right. That's
Oh, I
right.
love it. Okay.
And Sherry Hughes. And so we planned on having a special guest this morning, and that the schedule, we had a little bit of a scheduling conflict. So as any good oncology practice would do, we have to think on our feet, and so we got a little surprise episode this week.
You have the
So,
surprise.
well, I have the
I'm
surprise.
waiting
I have
for
the
it.
surprise.
He's teasing the
That's
surprise.
right. But before we get started, we had a special guest on episode 34. Her name is Erin Gratch. She's a good friend of several of us around here, a good friend of the program. And she was on and was actually celebrating her 6th cancer anniversary.
Mm-hmm.
So she'd been cancer-free for 6 years. And unfortunately, she's had a recurrence since then. So I wanted to kind of throw out a special recognition to Erin. She's just started chemo.
Mm-hmm.
So, Erin, you are in our thoughts, and we'll have you back on once you're finished with your treatment.
Yeah, Erin was, she stopped by last week.
Oh, that's right. She was
she
here.
came
Yeah,
to get
yeah.
like a second opinion.
Yeah,
and,
that's right.
She's doing good. She's looking good. And we know Erin has this. We're sending her our love and support and prayers.
Yeah,
But, this is something we can talk about as well in another future episode, the possibilities of recurrence, because, as you can see, that does happen. I don't know, Andy, how frequent it happens per different type of cancer.
It just depends on the cancer. It depends on the presenting stage. It depends on when they were. It's so many factors. And the funny thing about cancer is that doesn't follow the rules. So it can happen anytime, and you can be sailing along, and all of a sudden, boom, hits you.
Yep.
Exactly.
Yep. Exactly.
Scary.
So neither one of my guests today have any idea what's coming. So today, in keeping with the theme of school being back in session, we're going to do pop quiz today
Oh no.
Oh no!
for both of my guests.
Okay.
So,
Oh my goodness.
So anyway, we'll start out with Andy. And Andy, I'm going to make this pretty easy, but you are allowed one pass. If there's something I got to stump you with, but I don't think I will. But this will be a simple one. But I think I'm not sure everybody knows this. So you're a nurse practitioner.
Yes.
What is the difference between a nurse and a nurse practitioner?
I know this one. I know this one.
If you don't, we got a problem.
It's training. It's what we can do in the setting. So, registered nurses have either an associate's degree or a diploma, which is a 3-year degree, or a bachelor's degree. Nurse practitioners either have a master's degree or a doctorate. They actually have what they call a DNP nowadays, and they're actually weird because they're a doctor nurse, I guess, at that point. But we practice more similar to like a physician would practice. And you hear that term provider, and some people don't like it, but we provide healthcare. So in the state of Ohio, we can prescribe. We can prescribe diagnostics. We can prescribe meds. We see patients and do physicals. And those are things that are a little bit above what a registered nurse would be doing.
And oftentimes whenever I was trying to make an appointment to my, my general practitioner and couldn't get in to see her, I'd say, "Can I get the NP?" Because the NP can write those prescriptions, and they can, do those elevated services, and so that's a good way of looking at it. They're like doctor, nurse, doctor.
Yeah, for sure. I mean, there's this term out there, mid-level provider, but most nurse practitioners and PAs don't really like that term. We like the term advanced provider. Advanced practice, because we provide advanced care. We don't provide mid-level care.
Oh, right.
And
So there it is.
We kind of like that term better.
You mentioned PAs. What is a physician's assistant relative to a nurse practitioner?
So again, it depends on what state you're in. If you saw a PA and an NP, for example, functioning in a office setting, you might have a hard time discerning which is the NP, which is the PA, because how they function in the office is very similar. Their background's going to be a little bit different, and what they can do might be a little bit different based on, again, the state that they're in. So, most PAs are going to be able to prescribe in terms of the legal ease that they use, in terms of you have to be supervised versus you're collaborating with a physician. There's different language in place in different states.
Okay, gotcha.
Did he pass?
Yeah, no, he's doing well. He's doing well.
Uh-oh, here it
So
goes.
what I think there's like 1 million people that know that Sherry is a recovering meteorologist who now works here.
Recovering
CCA.
people are still asking me about the weather wherever I
believe
go.
I believe it. I'm just about to ask you about the weather.
Oh.
So Sherry, what is an isobar? You're allowed to pass.
God. Lines of equal barometric pressure.
Okay.
Isobar.
I should never have to care about that. That's just the meteorologists that care about that. Does that mean something to a meteorologist?
Well, I mean, yeah, because when you see pressures that are higher and lower, it means there's atmospheric change.
Okay.
Something happening in the atmosphere, and usually when there's a storm approaching, the lines of the isobar lines tend to kind of get a little bit closer together, and you see that there's something coming your way. So you learn to look for the isobars as well on those charts.
There you go.
And that helps you.
Who knew?
That helps. That helps
Well,
you.
Sherry did, apparently.
That helps you kind of decipher, and it's one of the elements or components to being able to forecast in meteorology. So I hope I got that.
No, you
right.
did. No, you did. You did. I mean, I had to Google it to even know whether.
Did you write down the answer?
I didn't write it down, but
Okay.
I Googled it before I asked
So
you.
you know that's right.
That's
right.
right. Oh,
Okay.
no, you're all over
Thank God.
it.
I was
You're all
like,
over it. Andy, so we established that you're a nurse practitioner, but you have a specialty in genetic counseling. So is that something where, in fact, I'm going to ask you a question I've asked you before, but because we're hearing more and more about genetic counseling, but even I think as people go to get the testing done, remind us again, what's the difference between germline and somatic testing, and why should I care?
Okay, that's a great question.
Wow.
Before I answer that question, in terms of these terms that we use, genetic counseling or genetic specialist, a lot of it's legal, a lot of it is it's confusing. There is an entity out there, a certified genetic counselor. So this is a person who has a master's degree in genetics, and their whole career is studying genetics, and they get a license in genetic counseling. And I'm not that.
Okay.
So just to specify that, but I have definitely additional training in genetics, and so can talk to people about their genetic risk and order tests and the like. In terms of difference between germline and somatic, the lines get blurred. We are testing both in a lot of people these days. Germline really refers to what we would inherit from our parents. So, and so basically to test this, you can randomly test any cell in your body, be it you see CSI where they're doing that cheek swab, or you spit in a cup, or a blood sample are usually the samples of choice. A somatic genetic test is really looking at a tumor, and oftentimes what makes a tumor special and what makes it unique, what makes it a tumor in general, is its genetics. And it tends to differ from every other cell in the body. So in order to get that testing done, you really need a piece of the tumor. So, and as we get more sci-fi these days, the old standby was, putting a needle into a tumor and sending it off to the lab and getting that tested. Nowadays, we actually can find fragments even of a tumor, what we call liquid biopsy in the blood, and determine these molecular markers, and even determine what kind of cancer that the person has by doing a blood test. But that's still somatic test. You're still doing tumor testing as opposed to that germline hereditary testing.
Hey, Andy, we're getting closer to time, so I want to flip the script. You ready? Please, Steve, tell us, now that you are continuing your treatment for prostate cancer, what is a PSA?
PSA, yeah. So it stands for prostate-specific antigen. And so I'll have Andy here to help correct me, but it basically indicates the presence. Well, how do I describe this? So an antigen is, what is an antigen?
Antigen in this case is just it's a fragment or a remnant
variable
of that tumor. Yeah.
So basically, I can describe it better by saying the PSA generally correlates with disease burden. So
It
generally,
can, yeah.
generally,
Yeah, it gets confusing sometimes when we know the person, for example, is getting worse.
Yeah.
Their disease is getting worse. You can see it on the scan; it's getting bigger. The tumor's getting bigger.
Yeah.
But their PSA stays stable.
Okay.
Yeah.
Which is confusing. All of a sudden, for whatever reason, that tumor is no longer shedding that PSA.
Oh, interesting.
So
Okay.
that gets confusing.
So
for people
why should
sometimes.
men really care about PSA, and what number should they be looking at in terms of being deemed healthy?
Yeah, so a PSA under 4 is considered normal, and so when you get screening for prostate cancer, it's a simple blood test. No fasting or anything involved. It's just a simple blood test, and just like women get their mammograms, we all should be getting colonoscopies. PSA is part of that routine screening for cancer that people should be getting.
Yep. All right, we'll close out with one final question for Andy then. So Andy,
Wait a minute, I got more questions.
I know, but that's all right.
No more meteorological questions
You're the
for me.
clinical. You're the clinical help. So anyway, but when we had you on the first time, you tortured me with trying to pronounce your name, and so we are proud to have with us today, Annie. We don't allow do-overs. Andy. Okay. All
No,
right.
we gotta.
Andy Guinagundo.
I'm sorry. No.
Guinea
No.
Gundo. Guinea Gundo.
Guinea.
All right, here we
Guinea.
go. All right. Andy
Guinea. Like,
Guinea
think of-
Gundo.
yeah, okay. No,
All right.
really, yeah.
With Annie. I don't know why I can't do this. All right. We may have to have you do this.
No. You're gonna do this.
Andy Guinea Gundo.
Well, thanks for having me, Steve.
Did I nail that one?
Yes.
All right, gotcha. I know that you.
I tortured you. You kind of tortured yourself.
I
but-
know that you torture your children by making them go to operas. So, what is your favorite opera and why?
Wow, that's a great question. What we just saw over the summer, La Boheme, was excellent. Cincinnati Opera has a long history. I didn't make my kids do anything. For the longest time, I'd be like, I'd make my wife go, or you're going by
Protective
yourself.
Services.
They
listen
came
up
with me.
here.
They wanted to come.
I just saw Aida, and it was really great.
All
It was
right,
a great
all
opera.
right.
Just saw that.
Some of the longest days I've ever spent were in operas. So anyway, thanks everybody for joining. This was fun, and we'll see you back here next week for episode 46. Everybody have a great week, and we'll see you next Wednesday. Take care.